Thank you. Um, the first speaker will be covering the topic of IPTP, but the speaker has changed, remains from Dr. Paula Ruiz Castillo from East Global, replacing Dr. Clara Menendez, and she will speak to IPTP implementation barriers and facilitators, a delivery through ANC strategies, which is a paper she presented to the recent WHO consultation on chemoprevention. Dr. Ruiz Castillo.
So good morning, everyone. I'll be speaking on IPTP implementation and its barriers through the ANC channel delivery. And this is part of a review work I did last year on chemoprevention implementation. And I looked into the operational research and implementation research on these topics.
Yes.
Yeah. So before I start on IPTP, I wanted to quickly review these definitions of this type of research that goes beyond basic science, because I believe they're very important. And if we can, I just put up here these definitions. One is implementation, the other one is operational research. Sometimes they get confused. One, implementation is more broad, whereas operational research focus more on specific programs and its operations and tends to address local programs. In general, both of them try to understand the barriers that prevent the access to the tools that we develop to the people, and overall improve health systems and healthcare delivery. So the malaria community has picked up on the importance on this type of research, and there are review papers already highlighting the presence of this in the literature. And even in the research agenda for malaria eradication, there is an entire chapter on health systems and operational research. So this is great news. However, still OR represents a very small percentage of the malaria research that's published today. So now focusing on IPTP and its delivery through ANC. This is just a timeline of the recent different WHO policy steps that happened in the last decade. This started way before, but I just put up the latest years. And what I want to highlight here is that while all of this was happening, in terms of implementation, the coverage of IPTP was very low. And in 2013, it was reported that only more or less 22% of coverage was achieved in 27 countries in sub-Saharan Africa. This led to a global call to action, which was an advocacy movement that happened here at ASTMH in 2015, trying to break those barriers to implementation of an intervention that we knew it worked. So what was the problem? This is what I call the surprise of IPTP implementation, is that in principle, we would think that if we link IPTP to ANC appointments, the implementation could be only problematic in areas where ANC attendance is very low. However, we've seen many times that even in places where ANC is high, the uptake of IPTP still remains low. So there is a mismatch over there. This is a graph from the recent malaria report from 2018, where we see the coverage of the 3 IPTP doses and ANC attendance in purple. And what I want to highlight here is the difference between the first dose and ANC attendance. And even though we find 70% of attendance to ANC, we see around 54% of delivery of the first dose of IPTP. So what I did more or less a year ago is a literature review on operational and implementation research, and I found a lot of literature, over 50 papers on this, and even 6 review articles already, that describe barriers and facilitators of this issue. I found that the methods they used in most of these papers were focus groups, targeted interviews, and observations, so very qualitative methods that are key for operational and implementation research. So after a lot of reading, I organized the barriers and facilitators that I found I did a mix of the different methods I found, and I divided in this type of wheel, which has on the left side in pink, what I found from the perspective of the health system, and on the right side in green, from the perspective of the mother and the women. So I found a lot of barriers and facilitators on each of these categories. So I think it was kind of like a perfect storm and a lot of little things that went wrong. So I try to summarize it, and I'll skip a couple just to highlight the important ones. So to start, in terms of the governance, I found as barriers that there were a lot of changes in the guidelines for the intervention, and sometimes conflicting indications. And this led to a lot of confusion, poor integration of ANC and other prevention services with IPTP and malaria programs, and many partners implementing at the same time. In terms of facilitators, effective leadership and strong political commitment, which we've seen in Zambia, and which is key, a good integration between the ANC and the malaria programs, and initiatives like MIPESA, which are Malaria and Pregnancy Network in East Africa, where program managers get together and share strategies and ideas to improve. In terms of financing, we've seen unstable funding and relying too much on external donors as barriers, and also having a specific budget for IPTP within the malaria budgets of the countries. On the other hand, countries which have a good domestic budgetary focus for IPTP have performed very well. Then in terms of the supply chain of the medicine and the technologies that we need for this intervention, we've seen drug stockouts, misuse for treatment sometimes instead of for prevention, and then slow procurement, especially in-country transportation, shortage of drinking water and even cups at the health facilities. This has been a huge problem, and difficulty estimating gestational age of the mom, so not knowing when to give the drug. And then sometimes not even having the guidelines printed at the health facilities has been a problem. In terms of facilitators, having a variety of sources for the drug has helped. It's seen in Tanzania, and just having safe drinking water available and free cups at the health facility. In terms of information systems, well monitoring and evaluation systems in place have helped. And sorry, that was the facilitator. In terms of the barriers, weak monitoring and evaluation systems, and even poor communication with the media, where we've seen examples of newspapers articles about IPTP with negative influences about the intervention. In terms of the service delivery, long distance in rural areas of the health facilities, poor infrastructure, and lack of offering IPTP from the health workers. And then in terms of facilitators, a quality of service assured through regular supervision. And lastly, in terms of human resources, a very important one, there's been reported a lack of training and confusion by the health workers on dosing and timing of the drug, lack of supervision, and health workers expressing doubts about the intervention themselves, so not really believing in it. And of course, understaffing in rural areas, and that leads to lack of motivation, feeling overworked, and low morale from the staff. On the other hand, from facilitators, good training and supervision and support from the health systems, and good understanding of the strategy itself, and the perception that this is very good for the mother, so they can convey it to the women. Now, on the other side of the wheel, the perspective from the women, an important component is the individual, which is sometimes lack of awareness and understanding of the intervention from the mom. So understanding the benefits and the fact that this is preventive and not treatment. And then misconception and hearsay about the safety of the drug. So believing you may have an abortion or a stillbirth. And even the knowledge, the thinking of that you have to take a drug in a full stomach, so refusing to do it when when the woman hasn't eaten before. And then also late attendance to ANC means we're late in the pregnancy to deliver, and opportunity cost of being at a health facility. In terms of facilitators, a good acceptance on malaria prevention drug from the woman's perspective, and believe in their safety and understand that it's very beneficial for her and the child. This was a key one, a sociocultural. So the environment of the mother was very important, and sometimes this was reflected in gender imbalance. So a lot of women need the husband's support to do this, and sometimes they don't have it. And then the stigma on pregnancy, so especially on adolescent, pregnancy before marriage, or without a recognized partner. And also a stigma for HIV screening during ANC visits. And then in terms of facilitators, having a partner that's supportive of using antimalarials, and an overall good community acceptance. Lastly, things that are related to the health system but perceived by the women are long travel distances sometimes, and restricted opening hours and long waiting times, so back to the opportunity cost again. And then they perceive sometimes a hostile treatment from the health workers, and that leads to women sometimes preferring going to a traditional birth attendant instead, and they won't receive IPTP over there. And then in terms of economic, although this should be a free intervention and the drug should be delivered for free, sometimes there are fees at the health facilities, or at least perceived fees. So women don't want to pay the cost. And then the opposite for the facilitators is trusting the ANC staff and having quality services at the health facilities, the fact that the drug is free of charge. And some strategies that have worked are communication campaigns on TV, radio, or even linking to other prevention services at ANC. So the lessons learned from this review was, first, like we said at the beginning, having high ANC coverage is not enough to have a good IPTP coverage. Physical access to the health facilities is not enough either, because sometimes there are shortages of drug and basic supplies and lack of motivated health workers. So these will need an overall strengthening of the health system, so a health systems approach. And lastly, at the individual level, so the women's level, high attendance and good resources is not enough either. We need the woman to be empowered and understand the benefits of this intervention, as well as good community support. So given this situation, in the last years, there has been alternatives coming up in research and community-based interventions to try. These are published papers, so it's just a summary of what I found, to try to find better delivery systems that get a higher coverage. And since in MESA, which at IS Global, we gather ongoing research projects on malaria, I wanted to show here that I found that currently, well, a month ago, there were 7 projects going on IPTP, on research, ongoing research right now, and 3 of those, the ones in blue, are specifically focusing on community delivery. So people are thinking about this and trying to find better ways to get this to the women. And lastly, since this is a chemo prevention panel, I just wanted to do a quick comparison between IPTP and SMC interventions. And what I found is that from the implementation and operational research, which is what I looked into, something that I found interesting is that for IPTP, a lot of this research was done post-implementation, and it was kind of like to understand what went wrong and what we needed to do better to increase coverage. However, for SMC, which happened later in time, a lot of the research on delivery, so operational research, was done pre and during implementation to find the best delivery modes, and it actually influenced WHO policy. Related to this, on IPTP, there is extensive literature, like I said at the beginning, looking at all of these variants and what went wrong, whereas for SMC, implementation and operational research was just done before implementation and not that much happened after. In terms of the factors that affected the uptake, we've seen there is a great sociocultural influence on IPTP, whereas for SMC, we've seen good coverage when you just have the required resources available. And there wasn't that much sociocultural or environment against it. And then, interestingly too, in IPTP, community-based delivery has been explored. It started to be explored recently, but it hasn't been implemented yet. Whereas for SMC, and I know the interventions are very different in nature, but for SMC, this was explored and it's actually how it's being done and is being implemented with the good enough resources. And lastly, to finish, to compare the two of them, for IPTP, we've seen that due to the low coverage, there was a huge advocacy movement, whereas for SMC, there was a great resource mobilization thanks to the Access SMC program. And then this also leads to the fact that once this program finished, there is concerns about the sustainability of delivery of SNC, so malaria programs have to take over now. Whereas for IPTP, if we manage to do it through ANC channels, it would be more sustainable. And just to finish, I want to thank you, my colleagues from MESA at IS Global, and happy to take any questions.
Let's see if there's any questions at this time. Just identify yourself, please.
Hi, I'm Bagvi Rao, Médecins Sans Frontières. Thank you for a lovely presentation. Two questions. Did you find any regional differences? Because you didn't sort of mention where most of your studies were coming from. So I wondered if you saw any regional differences, especially in terms of culture. And second,
Regional. Sorry, you said regional?
yes. And secondly, did worries around first trimester come up at all as a barrier to giving IPTP?
So for the first one, I didn't separate by region because the literature was huge, and it would be a good analysis to see because you might find some trends. But I just compiled all of the information and try to pick the important, give an overview. So yeah, I didn't do that analysis, but it would be interesting to see if, and I think we will always have to target to the context interventions anyway. And for the second question, sorry, I missed.
Concerns about first trimester specifically.
So women being more hesitant in the first trimester than after, or?
Right.
The time, no, not really. It was, yeah, they were, even if you see the coverage, even IPTP3, which is the latest, has the lowest coverage too. So the one that you give after, more later in the pregnancy. So I didn't see the time frame of the pregnancy having a big influence.
One more question.
Oh.
Can you hear me? Yeah, very nice. Question about a community-based approach. Well, you have now been more recent in the literature than I have. I just know from the earlier studies that there was a fear that women who would approach the community health workers, that they would not attend the antenatal clinic.
Yeah.
And has this been confirmed in later studies?
Actually, the question's out there because from those 6 papers I found that are published already, some of them found better coverage through community, but some of them did find lower ANC attendance. So and that's where I think the hesitancy comes from, that they are afraid. So they've seen both so far. So it's not the right solution either, completely. So those fears are out there, yeah. And it's been published, yeah. It's been reported.
Yeah, thank you.
Hi, sorry, I actually wanted to add from the previous question, there's some data coming out of community IPT in Burkina Faso that's actually showing that coverage of coverage of ANC 3 and 4 is higher in the areas where community IPT was implemented than in the control areas. And I think there's some information floating around about that as well. Or you can go to the MCSP website and there's a summary of this research.
Yeah, and some of the projects I think that are ongoing do IPTP community delivery, but then they encourage women to go to ANC at those community contacts. So they're trying to mix them